So let's begin with the blue or general tab. In this section we have two minor updates. First, Valley Care is no longer a destination to take victims of sexual assault. You'll take these patients to Washington Hospital or Highland Hospital, and you'll still take children to Children's Hospital. Next, we've updated our infection control and screening policy to allow for the use of P100 respirators when transporting patients who have a suspected infectious disease that is transmissible via the aerosolized route. If you're not going to be performing any aerosolized treatments, you can go ahead and use the N95 respirators. Let's go in depth into the smoke inhalation policy. Here's Ian Zakshevsky of Berkeley Fire and Fred CLARIDGE to give us more information.
Hydrogen cyanide is a mitochondrial toxin that is one of the most lethal toxins known to man. By inhibiting the body's ability to carry and metabolize oxygen, it forces the body into an anaerobic state, leading to profound lactic acidosis and death. Though significant cyanide poisoning is uncommon, field paramedics should be skilled in rapidly identifying and treating patients with suspected cyanide poisoning. Cyanide poisoning can be caused by a broad range of exposures. Some exposures can be from industrial applications such as in mining, photography, plastic and rubber manufacturing, rodent pesticides and fumigants, electroplating, and jewelry manufacture. Other exposure sources include hazardous material incidents, as well as potential terrorist attacks. However, the most common cause of cyanide poisoning is from the smoke produced by fires. Structure fires are responsible for over 3,200 deaths per year in the United States, and most of those deaths are due to inhalation of the products of combustion rather than from burns. On average, significant levels of cyanide poisoning are found in up to 35% of all fire victims. Some materials that release cyanide when burned include wool, silk, polyurethane, which is found in insulation and upholstery, plastics, synthetic rubber, and melamine resins, which are found in ordinary household goods. Vehicular fires can also be a significant source of cyanide. The clinical presentation of cyanide poisoning varies by the route, the duration, and the amount or the quantity of exposure. With ingestion or absorption, the toxicity may take minutes to hours to manifest, and symptoms may include GI irritation, vomiting, and abdominal pain. With cyanide exposure from smoke inhalation, about 60% of the population will report a bitter almond odor. Early symptoms may also include headache, anxiety, agitation, nausea, vertigo, weakness, and muscular trembling. Severe cyanide toxicity will lead to signs and symptoms of impending vascular collapse. These are the most important signs and symptoms as a paramedic to be vigilant of, and when coupled with a high index of suspicion for smoke inhalation, include patients that are unconscious or unresponsive, have active seizures, are apneic, hypotensive, or have soot in the mouth and nose with a severely altered level of consciousness. Differentiating between carbon monoxide poisoning and hydrogen cyanide exposure in the pre-hospital setting can be difficult, if not impossible, when treating a patient that's been exposed to heavy smoke. So it is imperative that a patient who meets the guidelines for significant signs and symptoms of smoke exposure be treated empirically for cyanide poisoning.
Now that Ian has talked a little bit about the basic principles of cyanide poisoning and smoke inhalation, let's talk a little bit about the treatment. Alameda County protocols allow for the administration of a sodium thiosulfate drip for smoke inhalation patients who meet certain criteria. Those criteria include unconsciousness or unresponsiveness, hypotension, or soot around the mouth or nose, along with severely altered levels of consciousness. The protocol adult dosage is 12.5 grams in a 50 milliliter solution, much like this one. It's given over 10 minutes. For a pediatric patient, it's 0.4 grams per kilogram, also over 10 minutes, with a maximum dose of 12.5, same as the adult. If you're like me, you don't want to have to figure out a pediatric drip rate when you have a severely ill pediatric patient. So it's a good idea to figure out those drip rates in advance. You can use 5 kilogram measurements, 5, 10, 15, 20, and so forth. You can also call the base hospital anytime you have a question about a drip rate, especially when you're administering a medication like this. One of the things that you have to remember about using a glass vial is to roll it over gently so that you can mix the medication. Take the guard off of a vented IV drip tubing and open up the vent. That assures that the medication is being administered properly. You would then run your tubing as you normally would. We're lucky to have this kind of a protocol in Alameda County for smoke inhalation patients.
We're going to be adopting the National Trauma Triage Guidelines this year. So here's Dr. Jocelyn Freeman-Garrick to talk more about this.
We're here at Alameda County Medical Center, Highland Hospital, one of your trauma receiving facilities, to talk about the trauma triage criteria policy change. As you know, the CDC reviews the trauma triage guidelines with the National Committee of Experts, and in 2007, some changes were made. Alameda County decided to adopt all of the recommended policy changes, and the major ones that I want to discuss are the Glasgow Coma Scale. Before, we were triaging patients with a GCS of less than 12. That's been increased to 14. So now GCS less than 14, and if they meet the rest of the trauma criteria, you should be transporting those patients to a trauma center. The other major change, which I want to elaborate on, is blunt injury. Before, if you had, for example, a patient in a rollover motor vehicle accident and they had airbag deployment and they could have blunt injury from their chest hitting the steering wheel, they would meet criteria. Now there's a focus on specific injuries and symptoms that correlate with that. So closed head injury, altered mental status, suspected thoracic injury, and the patient has flailed chest or obvious splinting and signs of respiratory distress, or suspected pelvic injury because they have an unstable pelvis. That's what the criteria states now versus an overall blunt injury to any viscous or bodily part. Now, paramedic judgment is still in the trauma triage guidelines. So, if in your opinion, when you're in the field, you have a patient that you're worried about, but they don't necessarily meet all of the other requirements in the guidelines, you should transport them to a trauma center. The trauma surgeons are conservative. They'd rather you bring the patient to a trauma center if you suspect an injury. You will never be faulted for being conservative in transporting a patient, even if they don't have a major bodily injury. Now, some questions arise with burn victims. If you have a burn victim who has 20%, 30% significant burns, partial thickness, full thickness burns, some medics and field personnel think they should transport those patients directly to a burn center. You know that we don't have any burn centers that are certified in Alameda County, so you'll be transporting those patients out of county to San Francisco, sometimes even to Davis, outside of Sacramento. The trauma surgeons request that you bring those patients to the nearest trauma center or hospital for them to be stabilized. The reason is sometimes, not sometimes, often, these patients have other injuries. So the burn won't kill them in the next 24 hours. What will is airway injury. What will is carbon monoxide or cyanide. What will is overwhelming infection. And the closest hospital can stabilize them, make sure they're safe for transport to our burn center, and then facilitate direct transfer to a burn center.